Hello, everyone. Here, this is Abdullah. So we're back with the third pathology mock exam, and we have Sadi here. So Sadi, can we start by defining the disseminated intravascular coagulopathy, or DIC, please?
DIC is a pathological consumptive coagulopathy characterized by widespread activation of coagulation pathways and deposition of microthrombi in the microvasculature, leading to decreased perfusion and subsequently leading to bleeding.
Okay. So yeah, well done. So it's a consumptive coagulopathy due to activation of the coagulation and fibrinolytic system. Just keep it simple, like we mentioned. It will lead to formation of thrombi and bleeding as well. What is the clinical presentation for DIC?
Tachycardia, tachypnea, shock, bleeding from orifices like nose, mouth, urinary pathways and rectum, multiple bruising around the body, and yes.
Yeah, well done. So if you're gonna add the two most characteristic lab results, what will it be?
Characteristic fibrin degradation products, D-dimer, and schistiocytes and bite cells in the peripheral smear.
Yeah, I think all of this is correct. Well done. But I think mainly it's a thrombocytopenia.
Oh, yes,
and decreased fibrinogen and increased fibrin degradation products. Okay, so these are the clinical presentation. Why does
clinical presentation we will also have to tell investigations, right?
No, to be honest, no. I know the answer here is just we're saying thrombocytopenia, but I wouldn't unless they ask me for it, to be honest. Because the clinical presentation means clinical presentation, okay? Which is, like patient, like you said, clinically tachycardia and shock and bleeding from orifices and microthrombi all over the body and so on, right? Can you tell me what are the causes, the most common causes of DIC? You don't have to mention all of them, just the most common causes.
Yes, sepsis, ARDS, massive burns, pancreatitis, massive transfusion, polytrauma.
Yeah, well done. Yeah, these are lots of causes. If I'm going to classify it, it's going to be trauma and burn and massive blood transfusion and massive hemorrhage. All right.
Yes.
That's it. These are the commonest causes for that. And obviously sepsis will be another one. What is the treatment? How would you treat a patient with DIC?
Fresh frozen plasma, individual clotting factors, platelet transfusion, packed RBCs in case of shock, and treatment of the cause. If there is an infection, we will give the antibiotics, and shifting the patient to an ICU setup. Yes, I think.
Yes. So initially, we need to start by treating the cause, like you mentioned. So 1, treating the cause. 2, supportive care. And 3 is transfusion. Okay.
Yes.
So treating the cause might be sepsis. So start by treating sepsis. It might be, the massive blood transfusion. You need to stop the massive blood transfusion, to start increasing temperature for the patient, and treat the cause. It might be severe hemorrhage, and that's when you need to transfuse the patient with blood. Supportive, the main system to be affected is respiratory system. You need to put your patient on oxygen, start resuscitation by fluid and electrolyte balance, and also consider platelet or blood transfusion and anticoagulation. And finally, transfusion, which is fresh frozen plasma, platelets, and the cryoprecipitate. So sad, like we said last time, try to give a classification to your management. First, let's say I'm going to treat the underlying cause and do some supportive care and start transfusion, and then I start breaking it down into little pieces. Okay.
Yes.
Well, who to involve in the care for this patient?
Your consultant, the anesthesia consultant, the interventionist, and the a transfusion specialist and the nurses. I think.
I mean, basically, it's when you're being asked this question, you need to answer outside of the scope of the usual care for the patient. Who are we going to involve?
Yes.
So I think anesthetist, hematology, and the responsible surgeon will need to be involved. But I wouldn't mention the nurses. I wouldn't mention the ward team. I'll just mention I mean, those are normally not involved in the everyday care for the patient. So I'll just mention them.
Okay.
Apart from the surgeon who is involved in the everyday care, but I would still just mention them. Okay. How are the platelets formed from the bone marrow?
Bone marrow has giant cells known as megakaryocytes, and they're responsible for formation of the platelets. Yes, that's all.
Yeah. So megakaryocytes by fragmentation. Okay. Megakaryocyte by fragmentation.
Fragmentation.
Functions
Yes.
of the platelet. What are the functions of the platelet?
Platelets' primary function is formation of temporary hemostatic plug in cases of microvascular injury. Secondary function, they have various growth factors in them. Yes, I think that will be.
So simply, simply it's two functions. One, adhesive function leading to formation of a platelet plug, and it activates the coagulation cascade.
Yes.
What are the indications of platelet transfusion?
Thrombocytopenia, that is quantitative deficiency like thrombocytopenia, infections like dengue fever, then qualitative defects in the platelet like Glassman thrombocytopenia, Bernard-Solier syndrome, autoimmune conditions like autoimmune thrombocytic purpura, DIC, and massive transfusion.
Yeah, excellent. Well done. So I think the way I classify it here, platelet dysfunction and the platelet destruction. All right. So platelet destruction, you have ITB and you have like DIC and any sort of condition that will lead to destruction of the platelet. Platelet dysfunction, which is any sort of like other type of thrombocytopenia, which might be patient on aspirin for a very long time or things like that. So consumption and or destruction and dysfunction of the platelet, and thrombocytopenia is defined less than 50 DIC and post-cardiopulmonary bypass as well. All right. What are the stages of hemostasis?
The first stage is temporary plug formation. Second is coagulative pathway and permanent plug. And third is fibrinolytic pathway for the breakdown of the fibrin plug.
Okay, maybe this space you need to go through it again. So it starts by puncture, which is injury to the endothelium, and this will lead to adhesion of the platelet to that by production of thromboxane A2, and after adhesion of the platelet to the wall, this will lead to activation of the coagulation cascade. I'm sorry, it starts actually by vasoconstriction. So injury to the endothelium, then vasoconstriction. That's number one, due to production of thromboxane A2 and serotonin. 2, platelet activation. It will adhere to the wall and aggregate and form a thrombin plug. And 3, coagulation cascade activation, whether it's intrinsic and extrinsic pathway, and this will lead to formation of a platelet plug of a fibrin-rich meshwork, which is very sort of that's called the thrombus, basically. All right. So fibrin meshwork. Okay. Well, what are the measures that you can do to reduce the intraoperative bleeding?
Smaller incision surgeries, try to use laparoscopic and other scopic methods when one can do that. Trying controlled hypotension, judicious use of cautery and coagulation, and correct temperature of the OT to prevent hypothermia, and use of drugs like tranexamic acid and adrenaline per op and finishing the surgery early, proper expertise, and the auto transfusion and all those. I don't know whether it will come in this or not. We do that.
Okay. So yeah, well done. You've answered a lot that is needed, but here I think cell savers, good hemostasis, and hypotensive technique. But like you said, using the laparoscope when possible, and all these kind of things, it's amazing and great. So I think, Saad, your knowledge is excellent. I'm really impressed by it. But I would advise that during your exam, try to make your answers very short, because the examiner,
Yes.
I believe, will not stop you. He's not going to stop you. And you might end up by losing your time. So try to say
Yes.
the commonest thing, maybe 3 or 4 things. And if the examiner wants you to answer more, they will ask you, all right? They will just say,
Yes.
do you have any more reason, or things like that, all right? Okay. Can you define what is massive blood transfusion?
Massive blood transfusion is 1 whole volume of blood in 24 hours, or 50% of the volume in 4 hours, or in cases of children, I think it is 40 ml per kg blood transfusion.
Okay. So yeah, we do have an adult, like you said, divided into adult and children. And yeah, you said it very correct. Okay. Can you tell me what are the complications of massive blood transfusion?
Massive blood transfusion can lead to DIC, hypothermia, hypocalcemia, hyperkalemia, metabolic acidosis, hyperuricemia, hemochromatosis, and transfusion-related immune reaction like graft versus host reaction, febrile reaction, ABO and RH incompatibility, and renal failures.
Yeah, excellent. So yeah, I mean, I'll have to stop you. Your knowledge is great. So I think complication, the way I classify it, it depends on the amount of fluid that you give. So you can cause your patient fluid overload and hypothermia, and this depends on the fluid, any kind of fluid that you can give to your patient. So overload and hypothermia, and you can say electrolyte imbalance, coagulopathy, and thrombocytopenia, and adult respiratory distress syndrome, or TRALI, transfusion related or transfusion associated lung injury. Okay. What are the early post-operative complications in AAA repair?
DIC as a result of massive transfusion, shock due to post-operative dehiscence and bleed, complications due to ischemia, that is mesenteric ischemia, spinal cord ischemia leading to paraplegia, and later complications like erectile dysfunction, urinary incontinence.
So Saad, again, Saad, I'm sorry, I'll really have to stop you. So again, the question is very specific, asking you about the early post-operative complications.
Yes.
So
okay.
try to make your answer short and focused on the main question. So the early post-operative complication is all about ischemia. So you have ischemia to the bowel, you have ischemia to the kidney, you have ischemia to the sexual function, you have ischemia to the spinal cord as well. All right. So these are the 4 ischemic sites: colonic ischemia, renal failure, sexual dysfunction, and the spinal cord ischemia. Thank you, Sarah, very much. I have to be from here. So you have a female patient coming with left iliac fossa pain, peritonitis, and diagnosed with ruptured diverticulitis. She had Hartmann procedure, and the sample was sent to pathology, and we found out she has endometriosis as well, in addition to the diverticulitis or the perforation. Okay. So question 1, can you define to me diverticulosis? What is diverticulosis?
Diverticulosis, it is the herniation of the submucosal layer from the outer layer of the mucosa as a result from the unique structure of the colon.
Okay. So yeah, so well done, Nazir. That's the right answer. But again, try not to jump to the next question, because the next question is pathophysiology, which is the unique structures. So try not to jump to the next question. Okay. So 2 is, what is the definition of diverticulitis?
Diverticulitis, it is the inflammation of the wall of the colon as a result from the obstructed diverticulum,
Yeah.
which leads
What is
to
the definition? That's fine. That was right. That was absolutely correct what you said. You don't have to add anything else. All right. So the next part is, what is the definition of diverticular disease?
I don't know.
Okay, so we have here three terms to differentiate between. All right. So diverticulosis is basically the pouch that you can find. Okay, but it's
Okay.
mostly asymptomatic, right? So you have it's outpouching of the submucosal layer of the colon through the wall, but it is asymptomatic. This is diverticulosis. So let's say you have a female patient coming to you with pancreatitis, and you're doing a CT scan for her, and the report says the patient has diverticulosis. It's outpouching of the submucosa. She never complained of it before. This is diverticulosis. Okay. Well,
Okay.
the patient came to you after that with some sort of pain in the left iliac fossa, and but she's not feverish. Her CRP is normal. She doesn't have any issue, but just some pain in the lower abdomen. You've done a CT scan for her. It shows diverticulosis, but now she is symptomatic. So now we call it diverticular disease. Okay. Well,
Okay.
she came back to you later with sudden severe pain and sort of high CRP, high white blood cells, a little bit feverish, and they came back to normal. Well, that's inflammation. So this is acute diverticulitis.
Diverticulitis.
Okay. Yeah.
Okay.
Next step is she came to you with a very high CRP, very unwell, and she is shocked. And you do an ultrasound where you found some free fluid in the abdomen. You do CT scan to her, you found some perforation. So this is perforation of the bowel, which is called diverticular perforation. Okay. Next step, after the same patient, she will have some sort of collection and an abscess formation. So you call this diverticular abscess. Inflammation can even start to spread more and more to the surrounding structures and can go to the bladder and the vagina and lead to formation of diverticular fistula. So these are the basic terms before we start diverticulosis or diverticulitis. Okay, so can you tell me the pathophysiology of diverticulosis?
Yes. The pathology is a result as a increase of the intraluminal pressure in the sigmoid colon, where the nerves and the vasa recta and the other connective tissue penetrate through the inner circular muscle coat. And it's too long. I have to explain all the pathology.
Yeah, you do.
Yeah, and there is a focal dyskinesia in the muscle walls that other than the sigmoid colon, which are covered by the external longitudinal layer of the muscularis propria. But in the colon, there is a like a tinea coli, which is formed of 3 bands. So the increase of this intraluminal pressure leads to increased contractions with the sequestration of the bowel segments, and this is enhanced by the low diet fiber and reduced stools and bulk stools.
Excellent. I agree. So to be honest, Nazir, yeah, the answer is wrong. I completely agree with you, but I think we can make it short. All right. So you have here 3 main causes. One is a unique structure of the muscularis propria, which you don't have an external longitudinal layer of the muscles, but you have 3 bands that's called tinea coli. That's number 1 covered. All right. Number 2, the vasa recta, which penetrate the submucosa to the outer wall, which represent some areas of weakness in the submucosal area. These are the vasa recta, as you see here. Okay, so you have here, this is the tinea coli, and these are the vasa recta. 3 is increased intra-abdominal pressure, and this happens due to exaggerated peristaltic contraction and spasmodic sequestration. So it's the same answer. I literally didn't add anything to what you said, but the main thing is to get it structured and organized so you can answer very quickly in your exam. So you have unique structure, vasa recta, and intra-abdominal pressure. About the unique structure, there is no outer longitudinal layer. It's only 3 tinea coli. That's it. Vasa recta, which is penetration to the wall, in the submucosa, which represents some areas of weaknesses in the wall. And then
Dr. Abdullah, I want to ask a
Yeah.
question. During the exam, really, so the examiner will let me to explain all the pathophysiology and all the points, or he will stop me, or I will have to mention just points, small points.
I don't think that they will stop you. They will be expecting you to answer appropriately. And just to know, the MRCS exam is really an exam about your language as well, on how you present yourself. All right. So I think it's not only about your knowledge. So you might have the fundamental knowledge, but you're presenting it in a slow way that will make you lose lots of marks and you'll not be able to pass. So I think to communicate effectively is one of the fundamental factors to be able to pass this exam, in my opinion.
Okay.
So I mean, it's the same answer.
Yes. Sorry, I have given. Sorry to interrupt. Since I have attempted once, I have an idea. They will not stop you. Even if you go on for 5 minutes, they will not stop you. But this will result in you wasting your time, and you will not be able to complete your questions within the 9 minutes. So if you feel that you know the answer, or you don't know the answer, or you know the answer, but you have to arrange it, so you can say to the examiner, I will come back to it, or I will pass this right now. Then you can answer the simpler questions, and afterwards you have enough time, then you can explain. But it's better to, usually in the knowledge sections, the time is quite adequate. But still, it's better to make it short and to the point, like Dr. Abdullah has been saying.
Okay, yeah.
Okay, thanks.
So Nazir, I mean, the main point here, what I'm trying to say is it's all about your communication. It's not just about your knowledge. So if you might have all the knowledge in the world, but you're unable to communicate them effectively. So like I said, the answer is yes, they are long, but you can make them very short and summarized. All right, that's the main point. Like Muhammad said, you can say I'll come back to this later, but personally, I'm not supportive to this, to be honest. You can do that if you don't know the answer. But if you know the answer, just summarize it. Don't take more than 1 minute in answering it. Okay?
Yes.
Great. So how neutrophils migrate to the site of inflammation? I think we've done this before, but I'm happy to do it again.
Okay, it's 4 steps. Number 1 is margination and rolling into the vessel wall. The second step is the firm adhesion to the endothelial wall. Number 3, our third step, it is transmigration along the endothelial cells, and lastly, the migration in the interstitial tissue towards the chemotactic substance.
Okay. Yeah, well done. That's it. I'm not gonna even read it. So you have here rolling, adherence, transmigration, and then chemotaxis. I mean, you can continue by phagocytosis and apoptosis at the end, but that's fine. What is the lifespan for neutrophils?
Several days. However, I'm not convinced of this answer.
7 days, is it? You said, did you say several days? It's 7 days, right? So 7 days will be the half-life for neutrophils. I know that you said several days, but it's 7 days. A few days.
Does it's strong?
Yeah, a few days following the surgery, the patient developed left inferior fossa collection. How would you explain that?
It's due to the intrapelvic collection and periuterine adhesions.
Okay, so Nazir, I think you're really stuck with the notes that you're reading, which is okay, it's not bad. But I think this is the right answer. It's not a problem. But if you remember when we explained it first, so we said that this patient has ruptured diverticulitis, right? Diagnosed with ruptured diverticulitis. So that could be one. It's a diverticular collection. So basically, intrapelvic collection from the diverticulitis, and we confirmed that they do have endometriosis and diverticulosis as well. So even endometriosis can make a collection in there from the hematoma that can lead to that. All right. So I know the answer here would be exactly like we said it, because but you can still mention diverticular abscess and even retained collection from the endometriosis or the diverticular the diverticulitis. Okay, good. Well, diverticular abscess. So you have a patient with 75-year-old female patient, and presented with left inferior quadrant abdominal pain and tenderness, which was acutely unwell and admitted to ICU. What's your differential diagnosis? Left inferior quadrant abdominal pain.
Left pain. So it's maybe a diverticular disease, a diverticulitis.
Yeah. So Nazir, again here, so you were stuck with the notes, which is okay, but you need to go outside it a little bit. I know the answer is just there for you, but that's not important. The main thing is how you answer the question. So if you have a patient, 75, female patient, who's left inferior quadrant abdominal pain, the differential could be very wide. It could be bowel obstruction. It could be bowel ischemia. It could be cancer. It could be mechanical obstruction. It could be sigmoid volvulus. It could be diverticulitis, diverticular abscess and collection. It could be endometriosis. It could be many, many things. So you need to mention as many differentials as you can, because this is very non-specific. I didn't give you any details, right? I just said a female patient who's left inferior quadrant abdominal pain. That's very non-specific. So the differential is so wide that you need to mention as many as you can from the differentials. If the question comes in this way, I'm not really sure about how the question comes in the exam, but let's say if it comes in this way, you need to mention as many differentials as you can and don't really focus on the abscess or the diverticular disease, all right? So you need to mention diverticulitis. Yes, it's 1 and 2, bowel obstruction, whether it's adhesion, constipation, sigmoid volvulus, even urinary colic, you can mention that as well, all right? Okay. Well, let's say you had an ABG results and it showed metabolic acidosis with partial compensation. Are you able to define shock for me?
Shock. It is a decreased the abdomen, the body needs due to reduced perfusion and oxygen.
Okay, I'm going to tell you one thing here. There are some definitions that you can make it up, okay? Like, let's say if I ask you to define diverticulosis, you can make it up. There are differences in here. Let's say I'm asking you to define what is familial adenomatous polyposis. Again, you can make it up. You can make it your own way. But shock, you really can't. You need to make the definition of shock as the standard definition of shock, because this is very important. That's fine. So the shock is acute circulatory failure with inadequate tissue perfusion causing cellular hypoxia. This is the basic definition of shock. Okay. Well, what kind of shock do you think this patient will be having? So she came with pain and tenderness, and she's very unwell. What do you think? What kind of shock will she have?
Maybe she has a septic shock.
Septic shock. Yeah, mostly it's going to be. Yeah, mostly it's going to be septic shock, but you can still mention, hypovolemic shock.
Hypovolemic shock.
She's dehydrated. Yeah, but mainly septic shock will be the main reason. Okay, so I mean, this is a very complex scenario, so I'm gonna start asking you about sepsis. Define sepsis, and these are one of the definitions that you can't make it up.
I really don't remember it because I need to collect all the definitions.
Yeah, that's fine. So sepsis is a life-threatening condition. So it's a life-threatening condition due to dysregulated host response to infection. It's as simple as that. Life-threatening organ dysfunction, dysregulated host response to infection. Well, as always, I'm sure that you got the idea of my notes so far. So the first line is the most important line, right? So what I'm going to add now, you can mention it in the exam, all right? So the signs of organ dysfunction can be defined as Q-SOFA score. And the reason why I mentioned Q-SOFA score in the second line, because this is a bit old, it's not recent, right? The Q-SOFA score was, I think, used until 2016. And after that, now they're using the NEWS score instead of Q-SOFA score. So to be honest, I wouldn't even mention it in the exam. I will just define sepsis as that. And if I'm being asked about it, okay. Go on.
No, I'm saying just the definition, as you said, is the most important.
Yeah, and also here you can just mention this if you're being asked for it. You can mention the risk, the mortality risk from it. Okay. Well, so now you define shock and you define sepsis. Can you define septic shock?
Septic shock also is acute circulatory failure due to the decreased oxygen demands with the infections.
Okay, so again, this one, again, you need to be a little bit changed. So it's a profound circulatory cellular metabolic abnormalities associated with greater risk of mortality than sepsis alone. It's 40%. But to be honest, if you want to like play smart here, you can define that one, define shock, and then two, define sepsis. So what was the definition of shock? Do you remember that? So it's acute circulatory failure with inadequate tissue perfusion causing cellular hypoxia. And the main reason for it is sepsis, which is a life-threatening organ dysfunction caused by dysregulated host response to infection. You can do that, okay? Examples of septic shocks, there are many examples, and these are very important. Patient with lactate more than 2 persistently despite resuscitation, or patient with persistent hypotension despite resuscitation, and patient that needs vasopressors. That means this patient is in septic shock. Okay, so basic principles of septic shock management. Have you ever heard of the 3-hour bundle and the 6-hour bundle for septic shock management?
Yeah, I read it from once before.
Okay. That's fine. Do you remember any of it? Can you mention any of them from what you read?
Actually, I'm not remembering now. Sorry.
Okay, that's fine. So you have 3-hour bundle and 6-hour bundle. The 3-hour bundle, basically you're trying to do the sepsis 6. The way I remember, Nazir, just listen to that. You will always remember it. The way I remember sepsis 6 from medical school is the word buffalo with just one L, all right? So buffalo. B is blood culture and bloods. U is urine output, okay? Or urine cultures. F is fluids. And A is antibiotic, L lactate, and O oxygen. So it's buffalo with just one L, not 2 L. All right?
Yes.
Oh, just one F. The 6-hour bundle is basically at this stage, the patient needs to be reviewed by a junior doctor, and this need to be started. We need to take blood culture and bloods and everything and send it urgently to the patient. Patient need to have the antibiotic within 1 hour of the presentation. Okay? The 6-hour bundle, so if the patient is not responding to treatment, you need to apply vasopressor to the patient to keep the mean arterial pressure more than 65 millimeter mercury. And I think remeasure the lactate and check if the patient is responding. Okay, so these are the sepsis and septic shock. So very quickly, we define sepsis. We know it's a dysregulated host response to infection, which is life-threatening with high mortality. We define septic shock, cellular metabolic abnormalities due to sepsis, basically, and it's even higher mortality. I don't know, the 6-hour and the 3-hour bundle. All right, let's go back to our questions. So we've done a CT for the, remember that patient with the left inferior quadrant pain. We've done a CT scan for them, and it showed diverticular abscess. What will be your management options?
Diverticular abscess management process. That would be conservative. I will start with the fluid hydrations, antibiotics, intravenous antibiotics, and that I don't know. Can you proceed with the answer?
That's fine. So I think it's basically diverticular abscess is an abscess, like any abscess in the body. So the basic management of an abscess is drainage. You need to drain it, right? And the next question after thinking about, obviously you're going to start your patient an antibiotic and prevent sepsis and so on. The next question after thinking about drainage, how I'm going to drain it. So I'm going to do like, is it open drainage, or can I do it in a different way? Because this is obviously is not like on the skin or something. It's inside the body. So I need to think about how can I access it. So you can do it by radiology or by open access, right? Or by the open surgery, right? So you have open drainage and image guided drainage. Both has advantage and disadvantage. Okay. So to be honest, if I'm being asked this question, I'll just answer, well, I need to do open drainage or image-guided drainage, and these both has advantage and disadvantage, and need to be decided with my consultant, for example. Okay, so now you might be asked about the advantage and disadvantage of each. So what do you think are the advantage for open drainage?
It will be much easier to localize the abscess and the drainage directly.
Okay.
Immediate relief, but I think that the disadvantage that may be a futile and maybe it will affect the general states of the patient.
Okay, so advantage, yes, it's proper drainage. You can give some good toilet to the abdomen, and you can make a stoma if needed. All right, that's the important bit. You can make a stoma if needed. Disadvantage, you're giving your patient general surgery, general anesthesia. It's a high risk with multiple comorbidities, and also wound infection can increase as well. All right. Well, image guided, what are the advantage?
Image guided, and I think that it will be less comorbidity and less invasive for the patient.
Yeah.
And also will do a proper drainage of them, and there's no wound
Yeah.
infection yet.
Yeah, no wound infection, less hospital stay. Disadvantage is less adequate drainage. You cannot really do any toilet, any peritoneal toilet, all right? And it's not suitable at all for making a stoma for the patient. So every case needs to be dealt with separately. So in this scenario, we covered our differential diagnosis, try to be as wide as you can. We know the definition of shock, and we went through the shock, and we know that this is a septic shock in this patient, and we know how to treat the abscess by drainage. And drainage is either radiological, which had the advantage of being less invasive, exposing the patient to less stress, and you can put drain in, but a disadvantage if you're not cleaning enough and you can't make a stoma, and the other way around in open drainage. All right, so these are diverticular abscess. Before that, you had a little bit more questions on this side. Well, so remember the same scenario. I mean, I'm sorry, I'm jumping between multiple scenarios, but I think that's easier for you because we're linking things together now, all right? So you remember this patient, the female patient with peritonitis and endometriosis, okay? So you obviously she's shocked. She's in sepsis. What kind of antibiotic would you like to give to her?
I will go for antibiotics. I give you gram-positive and gram-negative and anaerobic. So gram-positive for amoxicillin and clavulanic acid, and for gram-negative gentamicin, and for anaerobic metronidazole.
Okay, sounds pretty good. Yeah, so broad spectrum antibiotic, like I said, but mainly to be decided by the local trust policy is the main thing to mention, really. Okay, what is the initial assessment for? I mean, that's fine. I think these areas is not really covered in this station. It's just for myself really to remember. So when you have a patient with an diverticular disease coming unwell, your initial assessment is just do clinical examination. And we know that diverticulitis is self-limiting or abscess or perforation and collection. You know, investigation, CT is the main important thing. And you can do, you know, these are your differential diagnosis, okay? Initial management for this patient, well, the shock, like we mentioned. And I mean, just basically, we've covered all of this. Acute diverticulitis management, the main thing is to start your patient an antibiotic. Later management is basically you need to do colonic investigation and basically diagnose the patient, make sure they don't have any cancer or any polyps or anything like that. So Nazir, back to you. So, you know, how would you define endometriosis?
Endometriosis, it is the presence of the endometrial tissue in an ectopic site other than the uterus.
Okay, that's a very good definition. Well done, very short and nice, and defines it. Okay, what are the theories behind it?
There are three theories. Number one, the regurgitation theory. Number two, the vascular and lymphatic dissemination theory. Number three, the metaplastic theory. The regurgitation theory, it is depend on the endometrial tissue implants in ectopic site as a result of the retrograde flow of the menstruation endometrium, and it goes through into the peritoneal cavity. The vascular and lymphatic, it is the spread of the endometrial tissue from the uterus into other distant sites like the bone, lung, and the brain via the blood vessels and the lymphatic. The last one, the metaplastic, it is that endometrium arises from the silmic epithelium, which is the mesothelium of the pelvis and the abdomen, from which the Mullerian duct and the endometrium originate from the during embryonic development.
Okay. So yeah, well done. I think you started this very well, but again, you took a little bit longer to define everything. So look at it, it's just very short. Just make it really short. You started it very well. You mentioned 3 theories: regurgitation, vascular, lymphatic, and metaplastic. All right. If the examiner want to hear more things, so regurgitation, it's implantation into ectopic site. Vascular and lymphatic can spread via blood or lymph vessels. It's acting such as cancer. Metaplastic, it arises from the coelomic epithelium. That's it. It just shouldn't take more than like 40 seconds maximum. Okay. So why could it be painful?
Because of the intrapelvic bleeding and the periuterine adhesions.
Excellent. Does it increase the risk of cancer?
Yes, especially the ovarian cancer, 3.5-fold.
Okay, 100%. So it does increase the risk of cancer by almost 3.5-folds. Well done. I think you had like 4 or 5 stations in single station. But this is how, to be honest, this is in my opinion, how we should study. We should link things together. So this station leads to this station, and this leads to this, and so on. All right, great. So guys, I'm really sorry. I will have to go now.